Good morning, everyone. So I thank the organizers for giving me this opportunity. So first, coming to the basics of diastole. So as we have read in our first MBBS, diastole has got four components. It has got isovolumetric relaxation, rapid inflow through the mitral valve, diastasis, followed by atrial systole. And if we do our transmitral Doppler, the normal pattern which we see is E is more than A and E prime is more than A prime. And there are the grades of diastolic dysfunction that we all know, that grade 1 is E more than A, grade 2 is E becomes more than A, sorry, grade 1 is E less than A, grade 2 is E more than A, and in grade 3 and 4, E becomes nearly 2 times that of A with the reduction of E prime. So in the physiology of heart failure with preserved EF, what essentially happens is the LV end diastolic pressure goes up, the LV end diastolic volume comes down, and there's a reduction in the stroke volume as the ejection fraction is fixed. The elevated LV end diastolic pressure leads to an elevation of the left atrial pressure, leading to an elevation of the pulmonary venous pressure, pulmonary capillary wedge pressure, elevation of the pulmonary arterial pressure, which consequently leads to elevation of the RV end diastolic pressure, and finally the RA pressure gets elevated, leading to congestive cardiac failure. And this is the PV loop which is seen in patients with HFpEF. So as compared with the normal person, the LV end diastolic pressure goes up, the LV end diastolic volume comes down, and the stroke volume also comes down. So this is the summary of the hemodynamics, what happens in patients with heart failure with preserved EF. So in the algorithm where we for diagnosis of heart failure with preserved EF, so there are four components which have to be assessed. That is the average E by E prime more than 14, septal E prime less than 7 or lateral E prime less than 10, TR velocity more than 2.8, and the LA volume index more than 34. So out of these four, if more than 2 are positive, diastolic dysfunction is definitely there. If less than 2 are positive, then it is not there. But the gray zone is there when 50% become positive. That's what to do when 2 are positive. So this is another algorithm showing the same. So E by A less than 0.8 with E of less than 50 with grade 1 diastolic dysfunction, that indicates the LA pressure is normal. Again, when the E by A is more than 2, we know that it's a grade 3 diastolic dysfunction and the LA pressure is elevated. But when the E by A is is less than 0.8, E more than 50, or E by A is between 0.8 to 2, then we are again at a fix. We are not sure what actually is there. Same thing with the E prime velocity on tissue Doppler. The E prime is more than 10, it is normal. E prime is less than 10, we have to check for E by E prime. So E by E prime 9 to 12 is grade 2, E by E prime more than 13 is grade 3, and E by E prime less than 8 is grade 1. So if we subject a patient, a normal individual, to stress in the form of a treadmill or a ergometric exercise, what happens to the diastolic parameters? So the diastolic filling time gets shortened, the myocardial relaxation time gets shortened, diastolic filling is accelerated, there is increased suction force in the LV during early diastole, the LV EDP comes down, and the LA pressure is unchanged. So that leads to an increased transmitral gradient. It enhances the flow of blood from the LA to the LV across the mitral valve. So this was a study published in 2003 where they analyzed the effects of treadmill exercise on mitral inflow and annular velocities in healthy adults. They had included 31 healthy individuals, and they found that the transmitral, the E velocity got increased, and there was a proportional increase in the A velocity as well, and there was an increase in the E prime velocity as well. So the E by A ratio and the E by E prime ratio were unchanged in healthy individuals. What happens in patients with HFpEF post-stress? So this was a study where they included echo parameters as well as invasive hemodynamics. So what we found on baseline, patients with HFpEF, they were older and they had a higher BMI. And on echocardiogram, those with HFpEF, they had a higher E by E prime ratio, and they had evidence of LV hypertrophy and LA enlargement. Next, coming to cardiac cath at rest, what they found was those with HFpEF, they had higher RA pressure, higher PA systolic as well as mean pressure. The wedge pressure was also elevated. The LV EDP was more or less similar between the two groups. However, for the normal individuals, systolic blood pressure went up much higher. RA pressure, PA systolic pressure, mean PA pressure, wedge pressure, and LV EDP all went up significantly. However, it's interesting to note that the cardiac index came down in these patients with HFpEF.